Hello and welcome to the TXRECs Educational Series. This session is being recorded and will be posted on the TXREC.org webinars page if you want to review the content or share the information with your friends and colleagues. Our speaker today is Bruce Edmonds from West Texas HIT Rec. All attendees have been muted to block out background noise. If you have questions for Bruce, please post them in the chat block of the GoToWebinar pane. Our questions will be read to him at the end of his presentation. If we were unable to answer your questions during the allotted time, you will receive an answer via email. First, some information about our speaker. Bruce Edmonds has served as the Director of Regional Coordinators at the West Texas HIT Rec since 2011 and has recently been promoted to the Assistant Director for the West Texas Regional Extension Center. He has extensive experience in the health, IT, and managing large-scale and small-scale EHR implementations. As a skilled educator, Bruce has developed and presented complex medical information to a variety of audiences. Prior to his work at the Texas Tech University Health Science Center, he worked at the University of Texas at El Paso, serving as a program manager for the Computing Alliance of Hispanic Serving Institutions, an NIH grant committed to the advancement and recruitment of Hispanics in STEM fields across 11 higher education institutions. Bruce received a master's in information technology from the University of Texas at El Paso. Thank you for joining us, and I will now turn the webinar over to Bruce. And Bruce, the presentation is yours.
Great, thank you so much, and welcome everyone out there in the virtual world. Thank you for joining us today. I'm looking forward to this presentation. It has morphed a few times since I first created it. We're going to be talking not only about just a brief intro to meaningful use, which everybody knows about, but also the benefits beyond just EHR incentives. So what will you learn today? Well, during this session, we're going to talk a little bit about change management basics, which is a key component to all of this. We're going to identify some qualifying incentive programs and certifications aimed at improved care outside of meaningful use, and we're going to highlight the basic qualifications and guidelines for the CMS Obesity Incentive Program and certification. What I'm doing today is I'm going to give you a list of several options that are out there for you in terms of other incentives that you can couple with your meaningful use. You know, you have PQRS and other things like that, but I'm going to highlight some other programs where you can possibly bring in some additional revenue, and I will highlight one specific program that the West Texas HIT Rec has been implementing for about a year now, and just give you some ideas on that. We'll also have an open discussion on the basics of adoption and implementation of these quality programs, just within a standardized patient visit. This is not adding additional work to what you're already doing, and that's the concept behind it, so you guys can pick my brain a little bit about what physicians have been doing in West Texas with this and my experience with it to kind of help you along and see if we can help you implement this. And we're also going to let you know who to contact to begin the process of adoption and implementation within the clinical settings. So we will get started, and let's first talk about why you want to make the change. So first off, you're already doing it. You've implemented an EHR. They're pushing things on you that you need to be doing. So why not share the information you're already collecting and report it to different avenues and different folks and properly maximize revenue within your clinical setting or organization. So that's why you want to make the change. You're already doing it. Let's just take that information and share it in a way where you can bring in additional revenue. So what's the rationale behind all of this? Well, there's access. There are no other clinical areas in which a patient will interact with the health system more times than in a clinical setting with doctors, providers, and those things. It's where information sharing between providers occurs with such predictable regularity and within a finite period of time. So we understand there's a process to it that you guys have been going through, and it is very regular and it's very common. It has not changed very much in the past few decades. So There's consistent care. The environment in which patient care is often delivered is typified by largely routine, high volume, and brief encounters with both high risk and relatively healthy patients. So what happens? We're being consistent in care, but you have somebody who's extremely sick and you have someone who's extremely healthy, and you're basically having to devote the same amount of time to both, even though you would like to devote more time to another. Another thing is just clinical workflow. The workflow for almost every patient visit in the country has been amazingly uniform and has changed very little in the past few decades, and is starting to change now with the implementation of an EHR, but even then, most providers are sticking to the same routine and the same process that they've been doing for quite some time now. And obviously the rationale behind economics, from an economic perspective, because of the information needed for the record at the hospital as well as the office, maintaining paper records has become extremely expensive. Housing records, doing those types of things and making that transition, and obviously in terms of fee-for-service and those things, the documentation required from a quality standpoint is extremely important in terms of getting your reimbursement rates as a provider or as an organization, making sure that you can maximize that. So the economic purpose is, or the rationale behind it, is extremely important. So a lot of reasons, including clinical, financial, and risk reduction, the delivery of patient care, merits review and revision by both clinicians and healthcare information executives. Because of its unique information access needs, workflow, liability exposure, and requirements for consistent patient care is a perfect environment to implement information technology solutions. So this is not only the EHR, but it's also talking about other types of change and different types of implementation, just like the education system went through a change just about a decade ago. In 1997, they started implementing different types of technologies into the classroom, and now you can't go into a classroom without seeing a computer. This is kind of the transformation that clinical settings are going through now, where there's going to be a point where we're going to walk into a hospital, into an office, and it's going to become second nature to understand there's a computer there, they're documenting this, and the information is readily available. So how do we get there? Well, let's talk a little bit about change management. I'm sure some folks have seen this. This is a very common formula, but I will go through this quickly to just help you understand what type of change and what needs to occur in order for change to happen. The first thing is you need to be dissatisfied with your current state. So where are you now? Are you dissatisfied with that? That's the first thing that needs to happen. The second thing is you need to know where you want to get. That's your future state. So you have to have a goal in mind of where you want to get. And then obviously there's a process for change that's going to occur between now and your future state. And that's the basic formula. And then there's always a cost involved, whether it's human, financial, time, whatever it is. There's always a cost involved with change, and it's just a matter of managing all of that. So like I said, if you have your current state, you have to be dissatisfied with where you are now. A lot of providers are. A lot of providers are still trying to adjust. What's your desired future state? Is it being fully automated? Is it being able to collect data? Is it improving patient care? Everybody has these different future states that they feel are most pertinent to them. So there's a process, and the change process obviously involves people, different processes and technologies, and you have to have strategic planning and initiatives along the way to be able to get to that future state. So you work from now on from where you are towards where you want to get. Now, the 4 steps, and when we talk about change, it's always interesting that people talk about change as this big, huge global thing that's occurring. Really, in order for change to occur, it has to occur at the individual level. An individual at some point has to make the decision that they want change. So what do? As an individual, you want to be aware. You need to recognize that you need the change. It's not, as an organization, people understand it, but maybe your CEO, CFO, a specific position champion has to realize and be aware that change is required. And then you have to start gaining interest from your stakeholders, from different folks that are interested, what we call in project management, your sponsors, those folks that have to buy into this in order for the change to occur. So you have to be aware, there has to be a building of interest, and once that interest is generated, then you have to go through a trial phase and start working, and this is where you start doing workflow design, and you start looking at your process, and it's a trial and error process until you find what works, and once you find what works, then it's adoption, and it's that implementation phase of change. So it's awareness, interest, trial, and adoption. And it's not at an organizational level. This has to occur more on an individual level in order for it to kind of permeate out towards an organization. So once you decide on change, which a lot of you have, whether you've been forced to change or whether you were looking forward to the change or you've already been on an EHR for a while and it's now just standardized, that's fantastic. So we all know about the EHR incentive program. The Medicare and Medicaid EHR incentive program provides incentives to professionals, hospitals, critical access hospitals, which is big here in Texas, especially in West Texas, to adopt, implement, and upgrade meaningful use of certified technology. So I'm not going to go through the entire thing, but I will let you know a little bit about how meaningful use ties into quality programs. So we all know about meaningful use and the core measures and the menu measures. It's not what this presentation is about, but let's give you a little summary of what the purpose of meaningful use is. So first off, meaningful use is using certified EHR technology to improve quality, safety, efficiency, and reduce health disparities. And everybody's heard of triple aim. If you haven't, you can just Google triple aim, and everything really revolves around that. So it's also designed to engage patients and families in their health care, improve care coordination among providers, among organizations, between providers and organizations, state agencies, improve public and population health. It's looking at specific demographics, which is why they ask you to collect those things. Hispanics have a high tendency for obesity, hypertension, high blood pressure, those types of things, so you want to address those things. And you want to obviously maintain privacy and security. So the standards now between HIPAA and now in Texas House Bill 300, there's a lot that's pushing towards securing and really maintaining a record the way it's supposed to be maintained. I just read an article recently that's just, it is incredible that you can buy a stolen credit card for $5 on the black market today, yet a medical record can go for up to $10,000 with people stealing medical identities now more than they are clinical. So they're stealing clinical identities as opposed to identity theft of a financial manner. So privacy and security is going to become very big moving forward. So meaningful use is mandated in the law, but you know, you're going to receive incentives if you do it properly. So what else is out there? Beyond just what we have now with the CMS, you know, with the EHR incentive program, CMS has multiple programs that you've heard about PQRS that they're kind of pushing on you a little bit now. But there are other CMS incentives out there. NCQA has multiple certification opportunities out there. Certain payers, and I've only put 3 up there, but all payers are starting to buy into this, but you're looking at ACOs and those types of terms that are getting thrown out there with quality improvement. United Healthcare has programs. Aetna has a few programs. Blue Cross Blue Shield has programs for providers where you can participate and get some sort of incentive for starting to treat quality as opposed to quantity in patients, saying, okay, if you have a diabetic patient and you do these 13 things, we'll reimburse you at a higher rate. If you don't, then we need to address those issues. So all of those things are going on. And in researching this, what I have found out that the HEDIS measures life cycle, or HEDIS measures, is really where all of this is geared towards. So it's selecting, developing them, public comment, you know, implementing it your first year, how to report it, then evaluating it, and those types of things. But HEDIS is really at the core of all of these. If you're able to understand HEDIS measure, quality measures, you'll be able to do really well. And all of those HEDIS measures are found within an EHR certified system. So how do we pull that information out and report it? So here are other quality program options that are out there for you. A lot of you guys have heard of patient-centered medical home. So with patient-centered medical home, and as you guys go through this, I have hyperlinked all of this entire presentation. So anything in blue, when you guys access this presentation again, you can click on this. So if you're interested in NCQA certification for patient-centered medical home, you can click on that link, and it will take you to the different programs under NCQA for this. So NCQA allows for health plan accreditation, disease management, case management accreditation, all these different accreditations that help your practice either bring in more revenue or help you get accredited in a specific way where payers and other folks see you in a different way and reimburse you at different rates based on the quality of care that you're providing for your patients. We talked about Blue Cross Blue Shield, Aetna, United, and all these other, all HealthSpring, Humana, all these different payers have PCMH initiatives and clinical quality measures initiatives that you can participate in. So two of the ones that I was able to find online that have great information were United Health and Blue Cross Blue Shield, and this is all based on patient-centered medical homes. So you can click on this and see what type of offerings they have for patient-centered medical home initiatives that will help you bring in additional revenue. Other quality programs include state-based health or medical home initiatives. So there's something called CPC. CPC is run by CMS, and what that does is there's specific geographic regions where you can qualify for additional incentives, where you can report out certain information to them and they'll pay you for it. You can click on this link to see if you are part of one of those regions for the Comprehensive Primary Care Initiative. You guys have heard about accountable care organizations. There's what are called accountable care organizations, and these 33 quality measures from CMS, which talks about the fee for service. So here are all the standards and things and shared savings programs through CMS that you guys can start looking into. You have Medicare shared savings programs as well. So both of these kind of deal with the same thing. One is more geared towards ACOs, another one's geared more towards private practices and those things. A lot of you guys have heard about CMS 9010, and like I said, I'm hovering over this so you can see it's all linked and archived, and you can click to this if you're interested in these programs and see specifically what is out there for you. And obviously, pay for performance. There's a bunch of resources out there from ARC that will point you in the right direction to say, here are some payer incentives for you. If you're accepting Humana or HealthSpring or Blue Cross or Aetna or whoever it is, here's a really good list of different resources that help you tap into those different resources. I can't talk about them all, so what I'm going to do is, in West Texas, what we've done with the Regional Extension Center, we've started working with CMS on a CMS obesity incentive. So I'm going to highlight this program specifically, and hopefully you have some takeaways from this that will help you implement this, and then we'll put you in contact with the right folks to kind of help guide you along with these types of incentives. But there's a lot out there. I am just going to highlight CMS, the obesity incentive, which has actually been around since January of 2012, but not many people are aware of it. But let me go through this program for you and highlight what it is, and then we'll open it up at the end for just a discussion on that program and any other questions you might have. So let's talk about the CMS obesity incentive. The background is the former Secretary Thompson notes that obesity, and not only Thompson, but you know that Michelle Obama has been very big on obesity care and those types of things as her part of the White House and her initiative that she's been working on. So they understand that obesity is a critical public health problem in our country, and it causes millions of Americans to suffer unnecessary health problems and to die prematurely. So this is understood, they accept it. So what has happened is the Centers for Disease Control and Prevention has a report that obesity is now an epidemic in the United States, and that preventive services are critically important for early diagnosis of health problems and for promoting health behaviors that can reduce the occurrence of chronic conditions. So what this goes along in lines with patient education and just educating your patient to become more involved in their patient early intervention. So I will give you an example of me. I am not overweight. I am actually very thin and thought I was very fit. Went to go get my life insurance, and I found out my cholesterol was way over 200. So I had to go see my primary care physician. We started addressing my diet and things like that. So whether someone looks healthy or not, we're looking at preventive medicine, because my doctor said by age 45 or age 55, I would have full-blown diabetes, hypertension, I'd be extremely sick, and it would cost a lot more, and it'd be more difficult to address that chronic condition as opposed to just addressing diet in my 30s, as opposed to looking at and morphing into a chronic condition at age 45 and 55. So that's kind of the preventive services that they're talking about, but it's geared towards obesity. So obesity is directly or indirectly associated with many chronic diseases, including type 2 diabetes, cardiovascular disease, coronary heart disease, hypertension, stroke, high cholesterol, which is what I was talking about, low HDL, gallbladder disease, musculoskeletal disease, sleep apnea, respiratory problems, and some cancers. So this obesity is clinically tied into many, and there's many other things, but this is what I was able to pull out of the report in terms of background. So what is obesity? From a clinical standpoint, it's quite simple. You look at your BMI, your body mass index, and it's, for those of you who do not know what BMI is, it's a number calculated from a person's weight and height, and this ties into meaningful use. So you're having to do vitals, height, weight, and BMI is calculated, so you're already collecting this data. And it's a fairly easy way to perform and screen. Providers should complete a BMI for every single patient between age 2 and 74 in an outpatient setting for meaningful use. So you're already doing this. And BMI is interpreted using standard weight status categories that are the same for all adults 20 years and older. There's a different class of calculation for BMI for pediatrics, which we can offer as well. But because pediatricians don't necessarily accept Medicare and it's for an older population, I'm focusing on obesity for adults. BMI also allows people to compare their own weight status to that of the general population. I'm not going to get into the formula, not that important, but it's there for anybody who wants to look at it. So the standard weight status categories ranges this way. And what I'm going to focus on is this here. If you have a BMI over 30, basically you're considered obese, and you qualify to be able to get into the CMS obesity program as a patient, and you as a provider can include that person as a patient that you're going to be addressing. So BMI over 30 automatically qualifies that person for the obesity incentive. So where does the funding come from? So CMS supports what is called IBT, Intensive Behavioral Therapy for Obesity, consistent with framework developed by the U.S. Preventive Services Task Force, which was an independent group of national experts that worked to help improve health of Americans by making evidence-based, and that's the key, evidence-based recommendations about clinical preventive services. So CMS has determined that there is adequate evidence to conclude that this intensive behavioral therapy is reasonable and necessary for the prevention or early detection of illness or disability for things that roll under Part A or Part B under Medicare Part A or enrolled under Medicare Part B. So what is IBT? IBT for obesity consists of screening for obesity, which is the BMI. Then you're looking at nutritional assessment, which is what they did with me, intensive behavioral counseling, and this ties a lot into, especially in rural West Texas, you're looking at telemedicine and those types of interventions. So here's where telemedicine can start working through this, where you can do behavioral sessions. You don't need the person to show up. You can do a telemedicine visit to start assessing these folks and looking at BMI and weight loss and those types of things, and looking at diet and exercise. And then the fifth step would be what's called a 5A framework, which I'll talk about in terms of IBT for obesity. So the framework talks about assessing that person, what type of risk factors they have, providing advice. You want to give clear, specific, personalized behavior change advice. Most people understand they have a problem, but you have to help them change their mindset. So you have to advise them on it, and then they have to agree. So moving forward, when we talk about barriers, agreeing is probably the biggest barrier in terms of having a patient come in and do something. So you want to collaboratively agree on treatment goals and different types of methods. What is the patient comfortable with? What is the provider comfortable with? And then you want to assist that patient using this behavioral change to aid the patient on agreeing these goals, and then using skills and confidence and making sure that that change occurs. There's medical treatments you can do. Obviously, there's different medications and things that you can offer. Nutritional supplements, those types of things. There's a lot of different types of interventions in terms of what you want to do to assist this patient. And then finally, you want to arrange a schedule and follow-up contacts to provide support, plan adjustments, and referrals for more specialized treatments in case your initial plan of preventive doesn't work. You always want to be able to refer them as you would anyway. So that's the framework. It's assess, advise, agree, assist, and arrange, the 5 A's. So obesity funding, this is just some nutritional assessment products that are out there that you guys can use that are free. It doesn't cost money, but the NRI, so Nutrition Risk Index, the Mini Nutrition Assessment, is another one that you can use. So, and there's something called Determine, which is a brief questionnaire that you can actually do during the office visit. So it's just, it would be like a fall risk assessment or a psychological assessment where you ask a real simple question in the triage area where you ask, you know, what types of diseases do you have? Are you eating poorly? Is there tooth loss? Is there mouth pain? Is there economic hardship? So it addresses real specific questions, but it's a lot quicker. That way you don't have to do the full-blown assessments in order to qualify this person for the program. So how does it work? So for Medicare beneficiaries who are competent and alert at the time of counseling is provided, and those counseling is furnished by a qualified primary care physician or other primary care practitioner. And that's the big one. So a lot of doctors say, I don't have time to do this, but can my NP or an RN or somebody else do this? And as long as, and I'll show you what qualifies as a primary care physician or a primary care practitioner. And what you want to do is you're going to have, in short, for this reimbursement, you're going to have one face-to-face visit every week for the first month, and then a face-to-face visit every other week for months 2 through 6, and then a face visit every 3 months for months 7 through 12. And if the person's able to lose 3 kilos or 6.6 pounds in the first 6 months, then you've been successful with that individual. What you're trying to do is seeing that weight loss. I don't understand. It's kind of an arbitrary number. I don't understand where they got 3 kilos from, but that's what it is. And I'm going to show you what type of timeline you would have for your office visits. And these would be office visits outside of their regular visits. So if they're coming in for a follow-up for regular things, this is a completely different schedule of visits beyond. You cannot do this during a regular office visit that they're coming in for. This would be a completely different visit. So when you're looking at this, this is a really good example of what you want to do. So in the first month, each little star down here represents a visit. So you do 4 in the first month, then 1 every other week, the following subsequent months, and then you do 1 a month for the remaining months. And at month 6, you would see if they lost the 3 kilos. If they did, you just continue with your same plan. If not, then the plan doesn't stop if they haven't lost the weight. They just want to make sure that you can accurately reassess the readiness for change of this individual. Do they want to continue, or are they trying? Are you just not going to try anymore? And then restart again for the other 6 months to see if they can lose that weight. So it's in 6-month increments. So if they don't make it at the first plan, you just need to reassess and make sure that it's not something you're doing and it's the patient. Are they interested? Are you trying? Okay, let's reassess what we're doing with you and let's try again. So CMS covers now, so previously it would not cover these types of visits, but now it does cover it for primary care settings, which are independent clinics, outpatient hospitals, physician offices, and obviously state and local public health clinics as well. So CMS defines primary care setting as one that provides integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, so PCPs basically, and anybody involved within those PCPs, and practicing in the context of a family or a community. So sites that are excluded from this type of funding are emergency departments, inpatient hospitals, ambulatory surgical centers, independent diagnostic testing facilities, skilled nursing facilities, inpatient rehab facilities, and hospice are excluded from trying to implement this type of system. So here you go. So here are the type of primary care physician. So you can have a general practitioner, family practice. So basically we're looking at PCPs and then other primary care practitioners. And this is a question that people had asked me before. As a doctor, I don't have time. But as you can see, if you have an NP, you're more than welcome to use that NP to do this. Certified clinical nurse specialists also work, and physician assistants also qualify. So any of these, if you're any of these, you can implement this type of program. So what happened? So the funding is effective for claims on or after December 29th of 2011. Like I said, if you had already started seeing people, basically we started doing this January 1st of 2012 with our patients, but this actually was written into what we would call, I guess, law on November 29th, 2011. So patient progress has to be assessed. You have to document it in your records and your SOAP notes that this is being done. So the compensation works out to about $25 per visit for what's supposed to be a 15-minute average appointment. It's Medicare coinsurance, Part B deductibles are waived, and the obesity counseling is not separately payable with any other counter on the same day. So if they come in for their regular office visit, you can't tail this onto another visit where they're coming in. It has to be on a separate date, and it has to be a specific schedule just geared towards the obesity counseling itself. Now, claims, I took me a while to figure this out just in talking to folks, but claims have to be submitted with the G code G0447, and it has to contain this ICD-9 code, which is basically the V8530, which is a BMI code that's saying, yes, they've been diagnosed with a BMI over 30 or one of these other over 40 BMIs as well. So you just have to code it properly with an ICD-9 code, and you have to code it with your HCPCS code of G0447, and that will tell CMS, okay, this is an obesity diagnosis. We're going to pay them for this visit. So that's how you code it. What are the challenges? There's tons of challenges with this. The American Society of Bariatrics physicians strongly recommend that the definition of primary care be revised to include bariatric physicians and obesity medicine specialists who've been doing this for such a long time, and they're not in there now, and they're trying to work to get those folks in there to count towards that. They also suggest that physicians do not currently address obesity due to lack of formal training. You've never been paid on it, so you've really never paid that much attention to it. Just the lack of specialty training for your staff in terms of treating obesity. And before, obesity treatment had not been reimbursed, but now it is being reimbursed. So they've addressed that part of it. And obesity treatment is time-consuming. If you notice this, they're giving you a full year to address this. Now, I added one at the bottom in huge letters because I have a ton of physicians extremely interested in doing this, and they've implemented the system, they started billing, and their biggest issue has been the patient showing up to the visits, and patient compliance has been the biggest hurdle for them. It's not that they don't want to do it, it's getting that patient in the office to do the counseling. A lot of people, some doctors have even told me when they've diagnosed, said, you know what, your BMI is over 30, well, you're obese or you're overweight. When they use those words, people look at them and have yelled at physicians, thrown stuff at them. So it's trying to get that patient to accept where they are and accepting that they need to change. So that's the biggest thing. Compliance and patient compliance is the largest and the biggest issue. So patient compliance, patient compliance. I also have a bunch of references here for you in terms of this program with Medicaid and just different things that you can pull off of in terms of intensive care therapy and different things that have been done, different protocols that have been implemented for you. So once you go to this, you're more than welcome to read through this. Obviously, you can ask me any questions that you have about this. But so who do you contact? Well, a shameless plug for the RECs in Texas, but you can contact your regional extension center, your trusted advisor in all of this, and they can point you in the right direction. They can help you implement these types of things. But West Texas, we have the most experience with this, but I mean, you need to trust your RECs with this, and if you do need help, just reach out to them and have them talk to them about this and see what they can do to help you implement these programs and bring in additional revenue. So that's it for now. I wanted to leave enough time at the end of this to talk about anything or any questions that you might have. So I'm just going to open this up to a discussion and any questions that you might have. Thank you.
And I am not seeing any questions. So while we're waiting for questions, I'll put in a shameless plug of my own. On January 18th, we are doing another educational webinar, doing the next educational webinar in the series, and David Ninelsa of Medicare is going to be giving a presentation on an overview of Stage 2 changes. David will be giving an overview on the Stage 2 core and menu measures, and we hope to see you there. And I am still not seeing any questions. So I want to thank Bruce for taking time out of his busy day to share his knowledge with us. If you have any additional questions or any questions for Bruce, please send an email to TXREC using the email shown, info@texasrec.org, and we will make sure you get an answer. Thank you all very much for, oh, Carlos says thank you, Bruce and Susan. Thank you, Carlos. And I'll close this down now, and we'll see you next month. Goodbye.